Obesity was shown to be one of the major factors contributing to the severity of the symptoms, just because it's highly linked to the fat deposition under the tongue area, which kind of further pushes the tongue back against the back wall of the throat and collapses that oropharyngeal airway space.
All right, welcome to our 5th Get Expanded live event. My name is Patrick, and thank you for joining us tonight. Our mission here at Get Expanded is to bridge the gap between patients and providers, creating open, unbiased conversations around airway health, jaw development, and expansion-based treatments. Tonight, we'll be focusing on MARPE and obstructive sleep apnea. Presented to you by no other than Dr. Svitlana Koval, an airway-focused orthodontist known for her MARPE face protocol, treating patients globally from her practice in Boca Raton. As always, we'll wrap up with a live Q&A, so feel free to drop your questions in the chat, and we will try to get through all of them. So without further ado, Dr. Koval, I'll pass it over to you.
Thank you, Patrick. Thank you, JP. I'm glad to be here tonight with you and with everyone who's watching us today live, and then will join us after with the recording. So we will be talking about the treatment of obstructive sleep apnea and how MARPE in general, because we all know that MARPE is an umbrella term, and that also includes FME, it includes MSE, all sorts of appliances that are either bone anchored or tooth bone anchored, and that produce that mini screw assisted rapid palatal expansion. So just a couple words about me. Yes, we have been working on the MARPE face protocol that both tackles the midfacial expansion and also the mandibular advancement. And the way we do it, we use the direct printed aligners technology in our practice, and that allows us to advance the mandible via moving the bone, the mandibular bone as a whole, through guiding tooth movements and rearranging jaw-jaw relationships, without the use of the precision wings or any elastics as a direct means of moving the jaw forward. We have always also come up with the 3D guided piezocorticotomy protocol, which also allows us to preserve the position of the nasal septum while we're expanding the midface, and also preventing the majority of side effects of midfacial expansion that include some severe and moderate asymmetries, and also the perimaxillary suture fractures and fractures around that area. So we'll be talking about the obstructive sleep apnea tonight, and we were well informed that this is a chronic disorder, and that there are two distinct characteristics of obstructive sleep apnea. And just from the abbreviation, just from the name of the condition, we understand that there should be some degree of obstruction, meaning that there should be some degree of narrowing or complete collapse of the upper airway. So men, just by gender, by birth, are more prone to developing this condition, and almost 50% of men and 23% of women aged 40 to 85 years old have moderate sleep apnea. And when talking about the pathophysiology of obstructive sleep apnea, there are many pathophysiological, I would say, pathways, but the most up-to-date approach to diagnosing and to classifying the pathophysiology of this condition, I would say, was presented by Dr. Eckert from Harvard team, and published in multiple articles. That approach, that it includes several phenotypes. So it's more of a phenotypic classification based on specific patterns, which include primarily the anatomical phenotype, which, of course, that entitles to a narrow upper airway, just the presence of it. There's also poor contractility of upper airway dilator muscles. There's a high loop gain and a low respiratory arousal threshold. So most of the patients diagnosed with this condition would have some degree of a mixture of those events. And that might entail more of always the anatomical phenotype, which means that there will be always the presence of the restriction of the upper airway, and there will be some degree of those three additional phenotypes. There will be some degree of high loop gain, poor contractility, low respiratory arousal threshold, and so on. And when we talk about the upper airway, there will always and always be this anatomical restriction, which is essential to developing the obstructive sleep apnea. And patients may present with similar AHI indexes, but they will have different levels of restriction. And patients with the same levels of restriction or with different levels of restriction, they may have same AHI indexes. So AHI index being the most, I would say the simplistic way of classifying the severity of obstructive sleep apnea. It does not correlate too much, or not to a full degree, not on a one-to-one scale with the degree of narrowing of the upper airway. And we all understand that upper airway, it's structures that are involved not only in breathing patterns or breathing function, but also in swallowing, in speech, in chewing. And there are multiple structures involved in that. And there are bony structures, there are ligament structures, there are muscular structures and cartilaginous structures. And we also know that upper airway has two main portions: the so-called horizontal portion, which is the nasal passages and everything that extends from the entrance into the body, which is the nostrils, to up to that PNS portion, velopharynx. And then we have this nice vertical portion, which is all muscular, is just a muscular, I would say, hose that is highly dependent on the position of the tongue, on the curvature of the neck, on the position of the mandible and the surrounding structures. So it's not that one single structure or one single bone is purely determining, or is purely determines that size of the airway or the function of the airway. There are multiple structures that are involved into multiple functions that contribute to that size of the upper airway. And when we talk about the narrow upper airway, again, this first and very important phenotype is described by Dr. Eckert. There is still, even though it's not primarily defining and there's no one-to-one percent ratio in how narrow the narrowness of the upper airway and the severity of the obstructive sleep apnea, still there is some association, there is some link, and there are several articles, and I will be quoting another article a little bit later in this presentation that shows the direct measurements that we would be referring to when we look at the CBCT measurements and the, I would say, predisposition or the risk of obstructive sleep apnea when just looking at those CBCTs. So when the patient comes, we're looking at some anatomical dimensions. We're looking at the nasal base, maxillary base size, but we're also looking at the upper airway dimensions. Certain clue on if there is any predisposition, if there's any risk of developing that obstructive sleep apnea. So the article by Nilapo that shows this article is a systematic review, so that kind of covers multiple different publications, and that sums all that knowledge on upper airway morphology and the link to obstructive sleep apnea. When we talk about the anatomical phenotype, so we just mentioned that there is a vertical part of the airway, which is mostly muscular part, and this is the collapsible part. So it's not the nasal part, which is kind of covered and surrounded by skeletal by the bone, which is the nasal passages, the nasal aperture, and the maxillary halves. But this vertical part, which is the muscular part of the upper airway, this is the most collapsible part, and that can collapse in different dimensions, in different planes. It can collapse anteroposteriorly, it can collapse laterally, it can collapse concentrically. And it can also collapse at different levels, not only in specific patterns. So when we talk about the types of collapse, the most widely acknowledged is the anterior-posterior collapse. And we truly believe that the more advanced the mandible is, the better the result. It's not always true. Sometimes lateral collapse, which is the proximity of those lateral walls towards each other, the lateral walls of the upper airway, that causes severity, some degree of severity to the condition rather than that anterior-posterior position. And there's sometimes a concentrical collapse where the collapsing happens both in anterior-posterior and in lateral dimensions together at the same time. So when we talk about the levels in children, if we talk about children, the most frequently diagnosed collapse happens at the level of the velopharynx, because this is where the adenoids are located. So here we can see the constriction up to and resulting in 34 square millimeters of minimum cross section, or even I have seen patients with 10 millimeters of minimum cross section area. The second most prevalent constriction area is the area of the oropharynx, and these two areas are those linked to the position of the tongue, and the lateral, the oropharynx, is linked to the position of the tongue and the mandible. So if we see the retruded mandibular position, that kind of pushes the tongue backwards, and that further increases the risk of tongue collapsing against the lateral wall or the posterior wall of the upper airway, and decreasing that flow and increasing the collapsibility of the upper airway. So when we talk about the anatomical predispositions, of course, a narrow palate does not only decrease the available size for the tongue, which further pushes the tongue against the posterior wall and against the soft palate, causing the location of those constrictions in the velopharynx or oropharynx. The narrow palate also kind of locks mandible or mandibular position in a more restricted, recessed position. So the narrower the palate, the more teeth will be contacting in the posterior regions, not allowing this mandible to slide forward and to advance and to have this nice and natural growth when the growth actually happens. So while developing this midface, those children who have constricted narrow jaws during those years of active growth and development, those upper narrow jaws, they do not only limit the development of the midface, but they also, by definition, result in retruded lower jaws. Some cases, some patients, they overcome this restriction, the retruded maxillary position, and they develop nicely positioned lower jaw at the expense of low tongue posture. And there is a tongue tie, so the mandible develops to a full extent, but the maxilla always kind of rests in the retruded position. So that results in a class 3. But most of the times, the other portion of those patients, they develop those retruded positions, so pure skeletal class 2s. So this is the role of retrognathia, which was clearly defined as one of the anatomical factors contributing to the development of obstructive sleep apnea. And this is how the treatment, which is approved by the American Academy of Sleep Medicine, AASM, this treatment is the treatment with mandibular advancement devices that kind of focuses and targets this portion, this anatomical restriction, the retruded position of the mandible, with protruding the tongue by pulling this jaw forward and reopening the oropharyngeal airway space. So when we talk about the clinical guidelines that were provided by American Academy of Sleep Medicine, I'm not going to be going through this big scheme. You can find it in the article. It's cited at the bottom of the slide. But what I'm talking about is that the official guidelines on treatment, the golden standard of treatment of obstructive sleep apnea is, of course, using the positive air pressure machines, the PAP machines. And the most widely used machine is the continuous positive air pressure machine, the so-called CPAP. There's also automatic positive air pressure machines. The second is the oral appliance therapy, and the one of the well-proven approaches is the bimaxillary surgery, the maxillomandibular advancement surgery. There is also a range of surgical options that target the position of the soft tissues that kind of aim at reducing that crowding of the soft tissues at the area of the velopharynx, palate, and so forth. But lately, what we have been noticing is that the so-called maxillary and midfacial expansion options have also found its place in that range of surgical adjunct therapies that are now widely used for the treatment of obstructive sleep apnea and is recognized by the sleep physicians nowadays. So when we talk about those patients who are at high risk for obstructive sleep apnea, These are patients usually with the high BMI index, body mass index, more than 35. And the patients who, by definition, who come to the office and they are diagnosed with any of the following conditions, they are, by definition, having the diagnosis of obstructive sleep apnea because they are highly linked. So there's congestive heart failure, it's atrial fibrillation, it's refractory hypertension, it's type 2 diabetes, nocturnal dysrhythmia, stroke, pulmonary hypertension, high risk. It's patients with high risk driving populations and patients who are preoperative for bariatric surgery. So patients who who have one of those conditions, just by definition, they are those patients at risk and patients who are potentially diagnosed with obstructive sleep apnea. So when we talk about the outcomes of obstructive sleep apnea, we're talking about the resolution of the main symptoms that patients present with. When we talk about treatment, what are we looking at? We want to have patient improve their sleepiness symptoms, their daily daytime fatigue, the improvement overall of quality of life. Is the patient and spousal satisfaction, is adherence to therapy and avoidance factors of worsening disease, and of course the weight loss and weight control. So the success of not only MARPE treatment, but one of the as an option to treatment obstructive sleep apnea, the success in treatment of obstructive sleep apnea also highly depends on patient cooperation. So we're not anticipating that any sort of therapy would be a magic wand that would cover all the symptoms and resolve anything. It has to be teamwork. It has to be very cooperative. And of course, it's the weight management. It's some behavioral changes and sleep hygiene changes and improvements. And also, of course, the adherence to therapy. So again, what are the success metrics, the metrics of successful treatment of obstructive sleep apnea? We all know that we also always refer to the AHI index as one of the major metrics in treatment and diagnosing of obstructive sleep apnea. And when we talk about the successful treatment of obstructive sleep apnea, it's the AHI index that is decreased below 10 events an hour, sometimes even less than 5 events an hour, which means that kind of takes us to the complete resolution of obstructive sleep apnea. And sometimes it's just a reduction. So sometimes if the AHI indexes or RDI are reduced by 50%, it's also considered a successful treatment for this condition. Of course, symptom resolution. Lately, I've been noticing articles and publications showing a slightly different approach, which more of a kind of physiologic approach to success metrics, to the kind of measurement of the success rate with treatment, and it's called a sleep goal criteria, which means that we would anticipate the decrease in blood pressure. We would, of course, anticipate improvement in quality of life scores, better oxygen saturation, and reduced fatigue. And of course, it's always about weight loss. This is the box plot from one of the recent studies by Brunetto, Dr. Von Moon, published in 2022 in Journal of Progress in Orthodontics. So that just shows two cohorts, the controls and the patients treated with the MARPE or MSE appliance, that shows clear difference between the AHI before and after treatment. So we can, so the two last box plots, the two last figures on that screen, they show these two. They just show that they do not overlap, and their 50 percentiles, they have no common number. So it means that these numbers are purely different, and that AHI index is significantly reduced with this MARPE treatment. So this has just become one of the prospective trials, clinical trials, showing the effectiveness. And we all know that this type of study is considered one of the highest levels of evidence in research studies showing the effectiveness of certain treatments. So going back to that question of the use of CBCT in the practice and kind of the link between the CBCT and the severity of sleep apnea. So when we talk about the CBCT, just as written by Dania Tamimi in her book recently published in 2023, CBCT is not considered a golden standard of diagnosing sleep apnea, and we all know it. It's the sleep study, it's the polysomnographic study or at-home study. So most CBCT units, they take the images in the seated position or in a standing position. And with all of those measurements, the main component, the sleep, is missing, and the related forces of gravity also are missing, and the patient remains in their habitual position. So with those machines that do not restrict the position of the head, which do not have any sort of, I would say, anything that would change the position of the head from the habitual position, those machines, they reflect more of a natural bending of the airway, and any relationship between the neck bending and, I would say, kyphotic, scoliotic changes in the neck to the airway, while those machines that have the restriction to the head posture, they are a little bit decompensating what patient actually presents with. So we want to see that patient standing in their habitual upright position the way they usually posture themselves under normal circumstances, even though it's upright, it's not a supine position, but this is best kind of related to their natural state of posturing themselves. And that all truly reflects how their body posture compensates for that reduced airway. So that is the mesh, the picture of the mesh that shows the transition between the posterior, the PNS, that nasal passages, the choana level, into the vertical part of the airway. And we see that I've just mentioned here the two main parameters that I would be looking into when measuring the CBCT and measuring the upper airway. So I would be looking into the total volume, and I would be looking into the upper airway minimum cross-section area. So these are two main parameters that interest me. So this is an article, again, that I always refer to when talking about where we actually measure those two parameters. It's the article published in 2023 by Pablo Ecari, and the size of the upper airway, that vertical part, that is measured from the level of the ANS, PNS, the level of the maxillary or palatal plane, to the level of the superior anterior portion or border of the C4 of the fourth cervical spine. So that is the area designated by letter C on this image on the left side of the slide. So that's my favorite article, I would say. That's the article published in 2012 by Schendel and co-authors, and they took 1,000 patients and they divided them into age groups. And what they showed, they measured the upper airway total volume and the minimum cross sections, and they kind of showed the developmental curve of how the upper airway changes dimensionally through the growth and development. And what they showed is that the upper airway total volume, it's different from the minimum cross section. So the total volume is the actual cubic centimeters of volume inside the airway, and that's kind of the total volume inside that vertical portion. So that increases from 6 to 26, 30 years old, and that from then on it kind of slightly decreases, and that decreases more in women compared to men. So the more important parameter is the actual minimum cross-section area. And what the authors in that article showed is that if the minimum cross-section area, which does not change with growth, so that kind of stays even throughout the years, and that's why we don't have any age related references here. So we're looking at specific numbers, and if that number is below 150 square millimeters and is between 110 to 150, there is association, there is a link with mild sleep apnea, even though we cannot diagnose the presence of the disease with just measuring the CBCT and the upper airway minimum cross-section. If that upper airway minimum cross-section measures between 52 and 110, that kind of gives us an idea of association with some degree of risk of moderate sleep apnea. And if it's less than 52, we can talk about the risk of the severe sleep apnea. So the definition of the obstructive sleep apnea, what we're looking at. So this is the definition of the American Academy of Sleep Medicine, and it has to satisfy A plus B or just parameter C. So A plus B is either one of the, so it's one of A and plus B. So it's patient complains of sleepiness, non-restorative sleep, fatigue, insomnia symptoms, choking, breath holding, snoring, etc. And the patient, and we just mentioned that a little bit earlier, the patient who has been diagnosed with hypertension, mood disorder, cognitive dysfunction, coronary artery disease, stroke, congestive heart failure, and so on. And also a patient who has 5 or more obstructive sleep apnea events, apneas, hypopneas, RERAs, or etc. Or the patient who does not present with any of those, but has 15 or more. So it's A plus B or C. And so the essential features here would be episodes of complete apnea or partial hypopnea, upper airway obstruction. It would be episodes that results in reductions in blood oxygen concentration. And these episodes, just to level out, just to balance out this oxygen desaturation, that will be terminated by brief awakening. So that's why this sleep is considered fragmented. That's why that person who undergoes through those fluctuations, that person doesn't go into deeper levels of sleep and suffers from not being able to feel rested and after the long, even 10 hours of sleep. So both apneic and hypopnea events, they last none less than 10 seconds, and most of them happen in N1 and 2 REM sleep most of the times, and very rarely in N3 sleep. So we see a lot of patients, especially male patients, who are not whose AHI indexes do not reach that threshold of 5 events an hour and are within, I would say, maybe 2 up to 4.5, but they present with those severe, significant symptoms such as daytime sleepiness and the fatigue, and so symptoms that are very much likely kind of diagnosed as a sleep apnea, but they do not satisfy, like the AHI index is not high enough to be categorized as the obstructive sleep apnea. So in 1993, Dr. Christian Guilleminault with his team, they introduced the term of a UARS, so upper airway restrictive syndrome, which means that patient experiences the same symptoms, but their oxygen does not desaturate so that it would satisfy the criteria for apnea or hypopnea. So the patient, the HI is below 5 events an hour, and the oxygen just does not saturate. But still, that patient keeps awakening, and that sleep remains fragmented. Nowadays, this URS is the variant of obstructive sleep apnea, and again, these obstructive events, they result in arousals, but with minimum arterial oxygen desaturation. And when measured with an AHI index, different skeletal classifications, they respond differently. So what we've noticed is that when we start talking more about the kind of treatment of it and any interventions on the midfacial area, we can see that again, in our practice, in our experience, is that different skeletal classification, different skeletal arrangements, that they would respond to that midfacial expansion and to any procedures related in slightly different manner. What that means. I will be going through the series as just a couple of actual real-time treatments here, the patients who we did the expansion on, and just so you have an idea of the real world results and what to expect from this sort of treatment. So the fact that MARPI and MARPI treatment, midfacial expansion, in some patient groups significantly reduces their AHI indexes. There is no, I mean, we see a huge improvement in certain categories of patients with certain skeletal arrangements. And I would be talking which patients or which categories respond better than others. There are some categories that do not respond to the midfacial expansion right away that we expect to happen, I would say, within maybe 2 to 3 months from the beginning of treatment. Because what we do, we do the sleep study at the beginning of the treatment, or the patient brings their sleep study before they start their treatment, and then we repeat that sleep study, and then we repeat it again, because that protocol, the MARPE phase protocol, that is specifically designed to uh, to cover and to measure those symptoms, and to further treat those patients after the midfacial expansion, those patients that do not respond to the midfacial expansion with the full resolutions of their symptoms right away. So this patient here presented with the sleepiness and restorative sleep symptoms, insomnia, fatigue. We did MARPE expansion. We see that the total volume, it increased from 28.9 to 31, which just I mean, the baseline number 28 is pretty high. So we see, and from that table, from the article by Schendel, we saw that the average total upper airway volume would be 15, 14 cubic centimeters cc's. Here, the patient presented with 28, and we increased it to 31. So the patient already had that increased upper airway volume. That just gives us an idea is that it's not so much that the anterior posterior position, and a patient may present with very high and nice looking numbers, but still have a lot of those symptoms that kind of do not come together. So a patient will have very low AHI index, very nice numbers on the CBCT, but why is patient still presenting with those symptoms? So what we did, we expanded that patient, and the total expansion was the parallel mid-palatal separation, mid-palatal suture separation resulted in 5.42 at the area of the ANS, 6.32 at the area of the mid-palatal suture, and 5.85 at the area of the PNS. So that was a nice parallel expansion. And what happened here is that the patients started seeing improvements with their symptoms after MARPE, but not immediately after. After we started doing and aligning the mandibular position, after we started aligning this mandibular position relative to the neck region, relative to the nasal passages, so kind of lateral position of the mandible, not so the anterior posterior position, because you were able to see that this anterior position and the total volume size, they were great. They were way higher than the average numbers. So it was not that, it was something else. And you see that this is a sleep study, and the sleep studies that we usually do and analyze are the sleep studies with a type 2 device, which also includes the EEG sensor, so kind of gathers that information from the electroencephalographic, from the brain activity, and that can distinguish between the time in bed and the actual sleep time. While all the appliances that do not have any sort of a EEG input, they cannot distinguish between the actual sleep time. So they may very often underestimate the number of events, just because that EEG information gives way more input, way more data to distinguish certain certain events here. So we do see that the patient had the AHI index pre-treatment of 2.8, which is not considered a obstructive sleep apnea, but this patient had more events during the REM sleep. And this is the sleep study taken immediately after midfacial expansion. The midfacial expansion took about, I would say, 2 months. In our practice, it's usually anywhere between 6 to 10 weeks. And this particular patient was 8 weeks. So we did, so that reduced. I would say that was almost less than a 50% of reduction, but it's insignificant because both numbers are under the threshold of 5 events an hour. So the resulting what happened here? So it's just the comparison between the sleep study before and after. What we see on this screen here, the very first row is the actual movements of the chest. This is the concentration of the oxygen. We see that on the second second sleep study, the concentration of the oxygen did not drop below that red line, which it just indicates the 89%, which is kind of critical level of oxygen desaturation, while in the first with the first sleep study, it reached that level, at that threshold several times. The heart rate was kind of jumping more in the first study. And what we see here with the first study, the patient avoided the supine position. So the patient mainly remained on the left side, and then on the right side, and then on the left side again, and the right side again. So the supine position, which shows under letter S and this horizontal line indicated by S, the patient did not sleep too much on their back. While in the second study, the patient remained on their back throughout the whole sleep, the whole cycle, and with a supine position, which is considered as a risk factor and which increases the occurrence of those events, the AHI was still lower. So the expansion itself improved the sleep position during sleep. I mean, the occurrence of those events during sleep. The flow has increased, so we see more of like a wider pattern of airflow here. We do that snoring, even though it still existed during the sleep. The second sleep study, it is less frequent here on the second one, and the effort, which means that the brain generated effort and the effort generated by the chest, that was it has had way less fluctuations on the second sleep study compared to the first one. So what we see here is that the case two is the case with the moderate sleep apnea diagnosed before the treatment, and that moderate sleep apnea with the level of 25. And the total volume, you see the first CBCTs without the appliance, and the second as with the MARPE in place. The total volume increased from 7.9 to 9.6. So here, also what we do see on those renderings is that how this specific pattern of the increase of nasopharyngeal airway with MARPE. So we see that it all looks almost the same in every single patient when we do that expansion. So that part of the nasopharynx that increases together with the nasal passages. So that kind of follows, because with the parallel expansion, with that piezocorticotomy, assisted MARPE with the guided piezocorticotomy, that allows for a nice parallel expansion throughout, and that kind of drags those bones in the back of the palate, the horizontal portion of the palatine bone and the pterygoid processes of the sphenoid bone, and that kind of drags those lateral walls of the upper airway sideways, and that increases the lateral walls, the distance between those and the anterior posteriorly. It changes the architecture of that portion of the upper airway. So that just shows the overall expansion, and we see that it's 6.75 in the front, 8.10 and 7.2 in the very back. The HI index in this patient was 25 events an hour. That's clearly moderate, kind of approaching severe. And that patient did not go into N3 sleep. The patient did go, but not so much, but mainly remained in N1 and 2 sleep, which is very superficial sleep, and then frequent awakenings here, and a lot of apnea and hypopnea events. This is the HI after. So immediately after we expanded, the patient felt a lot of improvement. The patient HI index decreased. The patient no longer needed to sleep in this kind of 45-degree position with a high incline, with the thick pillows under their neck. So we do see that the architecture significantly changed in more episodes of N3. So what we see here is that the sleep architecture that improved, and when we compare both the before and after sleep studies, we do see that the heart rate, it's more even on the second sleep study, and we do see that, again, patient kind of goes back to their normal supine position, because we all like to sleep on our backs, and it's kind of more convenient, and that's the posture where we get most of those apneic and hypopneic events. But even though patient did maintain that position throughout the night, the number of those events was way less compared to the previous study. And we do see that there's way less fluctuations in airflow and the snoring events, even though we do see some spikes here on this screen. The effort is kind of more evenly distributed. So the sleep architecture overall looks way better on the second sleep study that was taken immediately after expansion. And again, I just want to be realistic about the expectations of this treatment, and we need to know that not everyone would respond to this treatment the same way compared to the other patient, and that it's not about the treatment, it's about understanding the treatment planning and understanding the individual patient features that contribute to their condition. And I just mentioned it's not that the main reason I started this presentation with those phenotypes described by Dr. Eckert is that we do see patients in our practice that that were expanded by 10 millimeters with midfacial expansion, and the mandibles were advanced, but there are still the patients who have been suffering from obstructive sleep apnea, who have very low arousal threshold, whose physiology did not have enough time to readjust to those normal levels of oxygen, and patients whose BMI indexes are more on the kind of high end. Those patients will take longer to get rid of those symptoms, or the symptoms it's not going to be a very like right away resolution with this treatment. So again, we need to understand that this treatment, just like anything else, just like a CPAP, mandibular advancement devices, anything, it's not once and done, and once we underwent this treatment, it's like everything is resolved. Our body responds to multiple factors, and again, obesity was shown to be one of the major factors contributing to the severity of the symptoms, just because it's highly linked to the fat deposition under the tongue area, and which kind of further pushes the tongue back against the back wall of the throat and collapses that oropharyngeal airway space. So the one of the biggest things about the treatment with MARPE is that, again, the treatment has to be planned in such a way that the steps following MARPE have to be sequenced to target the residual constriction of the upper airway. What that means is that MARPE primarily increases the nasovelopharyngeal airway space. With the MARPE or FME appliance in place, we understand that the tongue has less space when appliance is in the mouth, and that pushes the tongue either forward to avoid that position of the appliance, or the tongue starts pushing against that soft palate. If you see my cursor here, so the tongue, that gray mass here, starts pushing against the soft palate, and the soft palate approaches the back wall of the throat. So in patients with high angle cases, meaning that the angle between the maxillary plane and the mandibular plane is more of a obtuse, so it's kind of more open, those patients are more prone to continue having those symptoms even after expansion, until this open bite condition, the tongue posture, the occlusal plane orientation is not resolved. So the treatment is and will be planned in such a way that the mandibular plane is changed and it's rotated away from that posterior wall, and that the neck will be readjusting. And again, it's about a teamwork. It's always about teamwork. So that patient, you see, we have the same nice pattern of increase of the nasopharyngeal airway space, and the kind of the reduction here is linked to the posterior rotation of the mandible due to the expansion of the top, and due to the teeth rotations related to that, and the new position of the teeth. Regardless of whether we expand with MARPE or with FME, we'll still have a different relationship between the upper and the lower jaws. It's just FME doesn't have that much of a leaning against the teeth, or it doesn't have it at all, but MARPE does have. So at one or during like a shorter period of time, with some providers with longer period of time. So MARPE would have some degree of teeth flaring, of teeth movements that are part of the expansion itself. With FME less, but even with the FME, we still will have a different position of the mandible. So we cannot evaluate the position of the mandible or intermandibular maxillary position immediately after expansion, because mandible is disoriented. Mandible doesn't know where to land against, and the mandible will be landing against the kind of nearest point, which is one of the back teeth. So the mandible will be rotating and positioning itself just to stabilize against one of the back teeth, and that will cause that posterior rotation. So that patient presented with an HI of 12.9, and then after the treatment, it reduced just a little bit to 12.1. The reason I am bringing this up is just because the patients, again, what have been explaining until now is that patients with high angle cases, they take more time to resolve those symptoms, to change the rotation of the mandible, because those patients are just more capable, or they are predisposed to the open bite with the primary points of contact around the area of the back teeth, which just simply leads to the constriction of the upper airway. So what I was pointing at here, and it's just a couple of slides left here, is that it's not only the lateral expansion of the midface that matters for the treatment of the symptoms and to resolve the symptoms of obstructive sleep apnea and related signs of it, but it's also the orientation of the mandible. So it's the complex treatment planning here with this particular approach that matters. Just like with maxillomandibular advancement, it's both jaws that are involved in this process. So that's why MARPE alone cannot solve all the problems just on its own. It has to be a mutual kind of effort. It has to be the top and it has to be the bottom. And we all know that the top is the outward and forward movement, and it's always forward movement with MARPE and FME appliances, and with the mandible it just has to follow. And it has to follow in a certain pattern, so it has to be aligned with the neck and against the nasal passages as well. Upper airway orientation is very much related to the cervical spine, and the mandibular advancement, mandibular alignment is also related to the cervical spine. So we have to align all of those structures. And the orientation of the nasal passages, nasopharynx, has to be aligned with the vertical part of the upper airway, which is the pharynx as well, which is linked to the position of the neck. So this is the article I'm just expecting to be published within a couple of days. This is a case report, but what we want to show here in this case is that the skeletal class 3 patient who presented, and we did expansion with MARPE appliance on this patient, you see that the patient posture, this forward head posture and the kind of lifted chin was improved, just habitual reposturing of the neck from the midfacial expansion. And there is some degree of the rotation of the palatal plane indicated by ANS, PNS. And the kind of common knowledge is that, and a lot of articles have cited that there is a downward rotation. It's not always the case. So what we did here, we did the 3D Ceph evaluation and superimposition of before and after. There is a rotation, but there is a rotation in this particular case. What we saw, there was a rotation against around the center of the resistance, which is indicated by this the red circle in the middle of the palatal plane. And that rotation resulted in the downward rotation of the kind of ANS and the upward rotation of the PNS. So there was kind of clockwise rotation of the palatal plane, but the PNS went up, and the upper airway orientation also changed. So our next topic will be talking in January about the aesthetic kind of outcomes of MARPE expansion. And I believe there's a very big trend on it, especially with male patients, that highly changes the MARPE and FME, changes the facial structure. And what we've noticed here is that both treatments improve the facial aesthetics in women too, providing so-called facelift effect, which I'm very happy with, just having myself expanded by 5.5 millimeters. So there are multiple benefits with this treatment. And JP, Patrick, I'm ready for the questions and answers. Yeah, that's an amazing question. Again, in our practice, what we kind of preach is that the expansion, and again, I'm following those phenotypes, and I would be following them. Either there is any sleep disordered breathing, or there is any sort of, I would say, anatomical constriction, so any malocclusions present. The there is a sequence. The anatomy has to be changed first. And we all know that with the midfacial expansion, with any sort of the actual bone movement, there will be remodeling against the palatal plane. And there will be remodeling that is lasting for up to 12 months after we completed the expansion. This is what we have seen with our own studies, that the first points of consolidation, like the hardening, happens at the area of the PNS first, then followed by ANS, and then the mid palatal portion, it kind of hardens, solidifies the last. What that means is that once that portion is being remodeled and expanded, the tongue will feel that this portion is always brought a little bit down compared to the initial position. And that also means that the tongue doesn't need to travel all the way up compared to before, uh, with the appliance in and after expansion. So in our practice, the way we do it, we do the expansion, we wait until the appliance is ready to be removed, we start the myofunctional therapy, then we evaluate with the myofunctional therapist, speech language pathologist, if this patient is a candidate for the tongue tie release. Again, sometimes the collagen mixture of the lingual frenum is such that it has more of a elastic types of collagen to it, and that are more prone to being stretched compared to the, I would say, type 1 collagens or type 2 collagens. So sometimes that myofunctional therapy is just enough to position the tongue properly, but sometimes it's not enough, or there was an initial very developed tongue tie constriction in that area, and there was a lot of compensation, so that has to be released with the tongue tie release, and then it has to be followed by the myofunctional therapy again. So again, it's the expansion, it's the myofunctional therapy, evaluation for the tongue tie release, and then myofunctional therapy again. If you're referring to the MARPE alone, or with no other following, I would say, orthodontic rearrangement, then no. As I've mentioned, in my experience, UARS presents with very mild, with very subtle changes in the orientation between the nasal passages and that pharyngeal portion of the airway. So there will be some deviations, some kind of bending of that upper airway along the way. So that has to be addressed with the change in the mandibular position. Again, BMI and all those kind of postural, and at the very beginning, it has to be the sleep hygiene and the behavioral therapy and the postural changes, just to kind of level down those symptoms. Again, if you would clarify your question, MARPE alone in conjunction with the further orthodontic treatment, and I believe that can significantly improve those symptoms. Again, we are working as a team, and we need to understand what are the other factors contributing to that. Alcohol consumption, any benzodiazepines, any sort of medications that can contribute to that upper airway collapsibility, that also matters. So that is a good question. And SARPE, again, what that does, that increases the width of the maxilla, and that kind of cuts it below. So the what that helps with, so it can also is that there is no guarantee that the SARPE alone would be beneficial in this position. We don't know where that OSA, where is the main constriction. So you cannot just tell, I don't have enough information to answer that question at this point, because the best way to approach this would be to look at the CBCT to see where the main constriction is, what is the position of the mandible. Would you benefit at this particular surgical intervention alone, or you would benefit from MMA, or is there anything else? So I cannot give any comments on this particular case. Nothing, unfortunately, just because it's very limited on what we have in terms of information here. I would say that FME has huge benefits when the patient looks for aesthetics and maximum comfort. I would say that the initial phases with MARPE, when the MARPE has the framework going over the teeth and that interferes with the bite, that is a little bit of a discomfort. I would say that FME highly preserves the position of the teeth and does not produce those flaring. That's a big, huge benefit of it. And we don't need to decompensate much after the expansion itself. So there are certain benefits in terms of the comfort and the combination of FME with the previous aesthetic treatments, like patients who underwent aesthetic, reconstructive, restorative treatments like veneers, crowns, and we want to preserve that expensive dental work that was done before, restorative work. So the FME is way more superior in those cases. Absolutely. MARPE, I would say, is a kind of simpler, more predictable approach in terms of it's less sophisticated. But again, there are different approaches to MARPE and different techniques. A two-step technique, there's like one-step technique, the direct insertion, when the MARPE serves its own guide. So there are different approaches to that. If everyone is erupted, it's not in the way, and it's always a good thing to have as many teeth as possible, because the more teeth you have, the more bone you have around them, which is the best thing to do to have. If the question is whether they would be in the way or no, and after the expansion and when we do the kind of teeth rearrangements and tooth movements, we also move wisdom teeth if a patient has those in place. So that's fine, and every tooth can be moved as long as it's uh, fully shaped, and you can kind of grab the tooth and you can engage it with any sort of moving device. I'm super happy. I'm very happy. I can't stop talking about this, and I do see my facial changes. What I'm also incorporating as I'm planning my own treatment and all the piezo guidance and all the procedures, I tell all of my patients that I experiment a lot with what I do to myself, and I want to feel what is happening to me and kind of feel it from the inside, so I can share my experience with the patients. So I do experiment a lot with the liners that I plan for myself, and I do experiment with how much activation I put into them. And what I got rid of was first of all, I don't have those kind of runny noses anymore. I don't have the anything, so I can breathe. So that was just like a wow effect one day when I woke up, and that was at around, I would say, 4.5 millimeters of expansion, that I just woke up and I felt, hey, I can breathe, and I can feel this kind of cold air in the back of my nose. That was the first thing, and I don't have those runny noses anymore. I do feel that, I mean, the alignment of my lower jaw, which is kind of indirect effect, guided more by aligner treatment after following the midfacial expansion. I don't have that crazy clicking in my TMJs. So I had like a zigzag opening, a deviation of my mandible with multiple clicks. It was, you could hear it from, from a couple meters. It was very, very loud. Now I no longer have those. So there was some displacement, reduction, rearrangement in that area too. And I do see more symmetry to my face, to how I talk, and to how I see myself when I record myself, even though I'm still in treatment. But that's a huge thing. So I'm still working on kind of changing the inclination of my maxillary cant and moving my mandible forward. A little bit under a year so far. So yeah, I'm pretty satisfied. And a facelift, of course. So at that point, I didn't do the FME yet. I just started just introduced that treatment this year, and I had my MARPE on previous year. And you cannot do this treatment yourself. You need somebody to do that, and we don't have that many providers who offer this treatment in our country. So that is why I would tell you that I might even repeat this midfacial expansion and try FME this time. Yeah, this is how excited I am about this whole process. we're working on this, and I would say it's under 10, just to be fair enough. Facial changes are very highly dependent on the position of the mandible and the muscle tension and those muscular portions and the overall which side you do chew on. So patients may ask, hey, we did this midfacial expansion and now my face looks even more retruded. It's not that your face is more retruded, is that the mid face moved forward, but your mandible, it kind of rotated backwards a little bit and it remained in the same position. So that's why that MARPE face protocol, which includes both using the MARPI and the FME and everything, that whatever you use for the midfacial expansion. And I would say that I would put a equal sign between both of them in terms of the effects, is that in terms of the kind of benefits and outward and forward rotation and the separation of all of those perimaxillary sutures, it's the treatment that has to be planned in such a way that you know what you're doing to the rest of your face. So I would say that the effects of MARPI and FME are similar in terms of kind of outward and forward. But these are just the observations. You know that we're working on our research projects, and we do have a large number of patients, and we're working on our retrospective cohort study, and we're going to publish those results hopefully like within the first half of the next year. So it's just for now, I would like to have at least reasonable number of patients with MARPI to compare to the FME. I mean, the reasonable number of FME patients to compare to MARPI. That will be a very nice another kind of comparison study to see the results, how they differ. I can now it's more of an anecdotal. It's like we don't have that many cases that we can compare, and we don't have research that we haven't researched that difference yet. But we were coming with that. I like everything to be described in numbers. I would say I am careful about treating professional singers, if this is what you are referring to. I don't know. I have several professional singers reached out to me, but what I see is that if, whoever you take, well, the strongest voices in the music industry, they all had some degree of palatal vault and narrow palate and very high vaulted palate, and that architecture kind of contributed to their unique voices. So I would not uh, do any sort of intervention on those who have developed their unique voices, because they can that can interfere with the career and with the professional activity in this area. I do see a lot of fullness in here. I see a way more smoother skin in the area here of the midface. Again, that under eye area depends on the initial structure, just like with the long faces, with the pre-treatment downward rotation of the maxillary complex, we would see a little bit more of the downward, the under eye collapse compared to other skeletal classifications. So we have to be kind of careful in our expectations. And also it very much depends on individual characteristics, lifestyle, and so forth. So skin types, so some skin types are thinner, some are thicker. And again, there are multiple factors contributing to that. We cannot I cannot come up with any, I don't know, just generalizations in terms of this. It's very, very individual. And I would say that, again, just to put a line under all that, conclude with this in this question is that the patients with downward rotations of their midface, the patients with the so-called long face type, dolichofacial types, they are more prone to having those under eye collapse than patients with the irregular orientation of the palatal planes.
Okay, wonderful. Dr. Koval, thank you so much. we're gonna have to. We went way over time, but it's okay. We had some issues, technical issues today. Let's save the remaining questions for next call. And I know I saw some questions that were answered before, so in case we didn't answer everything, be sure to follow our Instagrams, both of ours. We're always posting a bunch of snippets from these live events, and then we post the full versions later, so you won't miss anything. But hey, save your questions. And our next call with Dr. Koval will be January 26th on aesthetics. So let's stay tuned to that. Dr. Koval, any final notes?
JP Patrick, thank you again for having me here. Thank you everyone for joining us today. And Merry Christmas. Let's enjoy and let's transition into our new year with hopes and expectations, and let's fulfill all our hopes next year.
Absolutely. Merry Christmas, everyone. Happy holidays. Until next time.
Thank you. Bye, everyone.
Good one.